Globe's most experienced and respected voices in health and healthcare. I'm Leah Willis, Chief of Staff at the Echo Institute at the University of New Mexico Health Sciences Center. Leading up to this conversation today, we solicited from you, our audience, some questions. We'll get to many of those today, and while there was too much for us to include in one interview, Dr. Berwick has already promised that he'll come back and do a second interview with us. And in the meantime, it is helpful for us to know what's top of mind for our audience so that we can focus on those issues in future conversations. If you're joining us on Zoom today, you can also click in the three dots at the bottom of your screen, select Q&A, and share your questions with us live. And if time permits, we'll answer some of those as well. So now, with housekeeping out of the way, I'd love to introduce our guest today. We're honored to welcome Dr. Dawn Berwick to our Voices That Echo conversation. A pediatrician by training, Dr. Berwick served as clinical professor of pediatrics and healthcare policy at Harvard Medical School, professor of health policy and management at the Harvard School of Public Health, and as a member of the staffs of Boston's Children's Hospital Medical Center, Massachusetts General Hospital, and Brigham and Women's Hospital. Driven by the challenges and opportunities that he witnessed in medical practice, Dr. Berwick co-founded and led the Institute of Healthcare Improvement for 19 years. And in 2010, he was appointed to lead the Centers for Medicare and Medicaid Services. He then returned to IHI to continue that work as President Emeritus and Senior Fellow and continues to serve as President Emeritus. Over the years, he has served on numerous boards, committees, councils, commissions, for governments, nonprofits, and national associations. Truly, he's worked the lives of 10 people in one, and he has received many awards for these efforts, including an appointment as Honorary Knight Commander of the British Empire by Queen Elizabeth II in recognition of his contributions to the advancement of the British National Health Service. He's published over 200 scientific articles and 6 books. Today's Voices That Echo conversation highlights the future of healthcare. What you might expect to hear is a lot of focus on technology like artificial intelligence. And we will, of course, touch on that somewhat. But what I think you'll be most interested to hear is how Dr. Berwick centers healthcare's future less on the technology itself and more on the problems it's trying to solve and the people it aims to serve. So with that, let's get into it. Dr. Berwick, welcome and thank you for joining Voices That Echo.
It's totally my privilege. I will accept any invitation offered by Project Echo. I've been with Echo in one role or another for well over a decade, maybe 15 years, and it's an amazing organization. It's great to join you. Thank you.
Well, thank you so much. We appreciate your time. And to start with, as I mentioned in your bio, you've had the career of 10 people rolled into one life. And I know we're all curious to hear how you're spending your time now. What are you up to these days?
Well, I'm in a transition. I have left the organization I founded, IHI, to move on to other tasks I want to take on, all
Mhm.
centered on improvement. I think that healthcare in the United States, in fact, globally, still lags way behind its potential. And there are reasons for that, and there are remedies. And I really want to work on that. I'm very, very concerned by the political atmosphere in the United States right now and the policies that I think are really health destroying. And I want to work hard on that on the political frontier. I also have the uh, the joy of sporting a new hip. I got a total hip replacement about 5 weeks ago, so I'm on the other side of the bed and really actually learning a lot as a patient,
Mhm.
and happy to celebrate what will be the mobility I'll get back from this miraculous treatment.
Fantastic. Well, I hope that recovery continues to go very well, as I know we're all eager to have you continue to share your leadership in the healthcare space as long as you're willing. So, as I understand it, you're also serving as the vice chair of Power to Patients. Can you tell us a little bit about that organization? And does that represent a shift in your thinking about the focus on healthcare moving forward, or do you see it more as an extension of your previous work?
An evolution for sure, but a big one.
Mhm.
That's part of what I'm doing right now with colleagues, Allison Brennan, Cliff Gauss, and Rick Gilfillan, longstanding colleagues.
Mhm.
We have formed a new 501(c)(3) organization called Power to Patients. I think you actually have the website
Mhm.
available that will be shown.
Mhm.
Here's the deal. I have, through the evolution of my thinking about improvement, over 40 years, every year I've grown in my understanding that that when patients, families, communities control care, when they are actually in the driver's seat, and we act
Mhm.
as servant leaders, servant experts, things turn out better. And it's going the other way. Healthcare today has been financialized to a level that really scares me. And many of the interests at work are about profit making and profiteering.
Mhm.
And in many cases, clinicians, doctors, nurses, pharmacists, others are not in the driver's seat, and patients are left behind. I'm very worried about that. Public polling shows that patients are uh, angry is not too mild, strong a word about lots of things, costs out of pocket that they no longer can sustain, um, uh, inability to find the help they want and need when
Mhm.
they need it, which is, by the way, where Project Echo is an amazing potential solution, and complexity. We've made a complex labyrinth for patients and families to enter, and they get lost and they get confused and they don't understand it.
Mhm.
Uh, we've been working on that, trying to make improvements, but I think it's an issue of distribution of power and control. And I
Mhm.
think we need to move power from uh, primarily financial interests that don't have patients first to the patients themselves. So Power to Patients is a new nonprofit. We're going to be asking patients all over the country to join us, hopefully by the millions, to begin
Mhm.
to exercise the kind of voice, political influence, and change that and become participants in change. We'll be focusing first probably on a couple of issues that are very much on patients' minds right now, such as denials of care through current
Mhm.
uh,
Mhm.
dangerous review processes and other things like that. So I'm pretty excited about it. I hope people listening to us on the meeting today will be log on to Power to Patients and see if you can help.
Thank you so much for sharing that, Dr. Berwick. And yes, to our audience, at the end of the conversation today, we will have a couple of QR codes up. So stick around for that. One of them will be the link to Power to Patients, so you'll be able to go directly to that site and learn more about it and how you can become involved. So, Dr. Berwick, you mentioned patient empowerment as at the forefront of the work that you're doing today. And patients these days, as we all know, have unprecedented access to information through AI, through apps on their phone, through devices they wear like phones and watches that all help inform their personal healthcare journey. How do you think these advancements change or enhance patients' relationships with their providers?
I think it's a choice. I'm
Mhm.
very excited by some of the potentials that AI bring. I already use AI myself in my work, and I'm going to be trained to do it more. We see benefits of AI already in many organizations in ambient listening, being able to hear what's going on and produce supportive documentation and even suggestions for both patients and families and the clinicians and clinicians like that. There is reason to believe AI could help improve our diagnostic excellence and acumen and to help us select the right treatments. Uh, None of that is proven yet. It's still in play, and I think the in sort of the political side of it is that who's going to be controlling this?
Yeah.
If AI becomes the tool of large corporations and especially for profit interests to extend their influence and gain control through gaining data, then we'll just deepen the hole we've dug for ourselves. If we find a way to bring AI into the home and the community in a way that really gives people power over what
Mhm.
happens to them through knowledge, through decision making and influence, and are able to control the dark side of AI, I think it could be maybe the biggest change in care in my lifetime. We still don't know. I serve now on a National Academy of Medicine committee whose job is to produce documentation on how AI can help improve patient safety. And I've been blown
Mhm.
away by the potential. We have experts there who are showing really, in some cases, proven models where patients get safer when AI is in the game. But we've got a ways to go. It kind of links back to the power to patients piece because
Right.
we can't let AI and the corporate interests that drive it for profit control how AI enters. It probably enters our lives, uh, not just healthcare. So what am I? Hopeful and wary, and that's how I'm feeling about it.
Cautiously optimistic, we'll say. Yeah. Okay. Um, So over the years, you mentioned, profiteering as one of the challenges of our healthcare system today. Over the years, you have, in many settings, powerfully captured some of the core problems of our health system, such as rising costs, access challenges, clinician burnout, and corporate profiteering specifically. As you look out on the horizon, what are some of the solutions or forces for positive change that are most exciting you or inspiring you the most?
Yeah. I think maybe I should begin with a positive comment, which is, I mean, look at me. I was really in pain for a year trying to walk around, and now healthcare has given me a new hip. Already I can tell it's going to revolutionize my life and make the next years ahead much better. Uh, Members of my family have had their lives saved by
Mhm,
pretty technical interventions and skill. Healthcare can do a lot. And in the public health space, we also know a lot about keeping people healthy. So I guess we
mhm,
need to acknowledge and celebrate the gains. But the way we've implemented uh, those gains especially in the United States, it's been now turned over to profit motive organizations. I
mhm,
don't generally tend to think of them as evil, but they've got job one is to returns to shareholders and increase margins,
mhm,
and sometimes, in fact, far too often at the expense of patients. This has got to stop, and it's getting worse over time. Now, three-quarters of doctors are employed by corporations, some of whom are for-profit and driven that way. And even the not-for-profit sector tends to look at the budget and the balance sheet far too much except what's as opposed to what's happening to patients. Hospitals are more and more owned by venture capital. We have very good scientific evidence now, studies showing that when private equity takes over a hospital or a nursing home or an autism program, quality goes down and costs go up.
mhm,
Uh, I'm pretty distressed. I think it's one of the engines. Profiteering and having profit drive instead of patient interests is one of the engines of uh, increasing disappointment with some of how healthcare functions. How to change that? I think some of it has to be with legislation. We need to put
mhm,
restrictions on what I think are actually right now not the illegal, but I would call them immoral or manipulative or
mhm,
self-interested activities of all sorts of players. And nobody's not doing this right now, whether you look at, pharma or hospitals or insurance companies or physicians and physician groups. Money's playing a very, very big role. And I want to see that decrease and put patients ahead. I'm a fan of having patients in governance. I think I would, if I could wave a wand, I would have legislation that says if you're setting up a hospital board or board of a integrated care system, a substantial number of the members of the board have to be patients, people with
mhm,
lived experience, with real voice. Um, there are some anomalies in the way we code and bill that are, again, manipulative, and they need to be stopped. We have seen some progress on that on the federal side, but we need to work at this. I would like to see us have a national goal that reconciles the desperate need for cost containment, especially for out-of-pocket costs for patients on the one hand, and assuring that the quality of care is improved instead of deteriorates. I'll say one final thing. My whole career has been spent understanding and trying to advance quality of care. And let me tell you, I am more convinced than when I started years ago that when you really focus on need, when you're really addressing the needs of patients, families, and communities and improving the processes that serve them, costs go down, not up. Uh,
mhm,
we pay a high price for the defects that have found their way into healthcare. And I think that the idea that we have to give up quality in order to contain costs is absolutely exactly wrong.
mhm.
That's guided my work and will continue to.
Thank you so much for that response. And I feel like I could pull on any number of a dozen of threads there for future conversation. But now, actually, I'm going to transition to a question that we received in advance from one of our audience members. Given what you've just shared about, profiteering, patients being decentered, um, how do we rebuild trust in science and healthcare?
That's a big one. Well, first, I think rebuilding trust means being trustworthy. if we say with on one side that we're working on behalf of patients and families to help them restore and preserve health, and on the other hand, engage in payment mechanisms and creating denials of care and demoralizing the healthcare workforce, we're speaking out of both sides of our mouth, and that doesn't work. That doesn't earn trust to say one thing and do another. So I think the first interrogation is, are we trustworthy? Would you be willing to take your mother or your child into this system and with full confidence turn their fate over to the
Mhm.
system that you are leading or funding or regulating? And I think too often the answer is no. For example, we know there are major problems in patient safety. Uh, I've been in rooms of 1,000 people and say, raise your hand if you've been the victim of a medical error or an injury. And this is not intentional. Let's be real clear. We're not talking about intentional sabotage but just plain systems that don't work. And every hand goes up. So we know that it's pervasive, and yet we do not have commitment and activity in the boardroom of the American healthcare system, or even in the governance of the American healthcare system on the public side, to make care continually safer. We say it, but we don't do it. Who would trust us if we keep saying and not doing?
Mhm.
I think the profiteering piece is another piece of it. As long as the public understands that see that executives in healthcare are earning, three, four, 500 times the income of their lowest paid employees, are going home with, you know, uh, tens of millions of dollars of salary and income. As long as they see corporations sequestering more and more funds for their own use, the more they doubt whether we're really in this for them. So
Mhm.
there's a connection there. I am looking now, I think, hopefully to more professional leadership on this front. Right now, our professional guilds, they're basically unions. Go to their websites and you'll see arguments for being paid more, for restricting the prerogatives of other professions. No, no, no. The professions need to step up and say, job one is making sure people get the care they need and want. And our self-interest is not job one. Job one
Mhm.
is mission. And we have to, I think we really need to act that way. Let me say one other thing, which is this
Mhm.
is not a war between the interests of the providers, the clinicians, and the interests of patients. Not at all. The
Mhm.
idea that somehow the doctors and nurses and pharmacists are actively doing harm in order to line their pockets or to whatever, keep power, that's not right. That may be true of some organizations, but most clinicians really do want to help patients. So they are frustrated. And as you said, Leah, demoralized and
Mhm.
decathecting their work when they're not supported by the healthcare, by the system to do the work that adds meaning to their lives. And that needs to change, or we're going to continue to pay a price. So I'd like to make a plea for people to understand the
Yeah.
interests of clinicians and the interests of patients in this shift of power I'm talking about are aligned. They're consonant, and we can do this together if the professions get more mobilized as patients get more mobilized.
Oh, thank you for that. You mentioned healthcare leaders and clinicians and their role in this conversation and their connection to patients. And you've inspired generations of healthcare leaders over the years. And as we're taking your calls to action here, I'd be curious what your thoughts are on what are the skills or perhaps even personal qualities that you feel like today's and tomorrow's healthcare leaders really need to have in order to move us into the next phase.
It begins with values, and I'm optimistic. My
Mhm.
daughter is kind of early mid-career hospitalist,
Mhm.
loves being a doctor, works in a large medical center, and comes home every day excited by what she is able to do for patients. She's also become interested in medical education, so she's really helping young professionals in preparation uh, cope with and
Mhm.
grow under sometimes very stressful circumstances. So the youth give me hope. I
Mhm.
think the list of skills that are needed is a little different from what I was trained for. We're just talking about a shift of power. What does that mean for a doctor? to
Mhm.
walk into a room and understand that not just the patient comes first, but the patient actually has knowledge, information, and the right to basically control what happens. Not Don't give me an extreme case where they're asking for morphine. We have to give them morphine. No, that's not right. But overall, most patients and families are quite reasonable, and they want to have the care that improves what matters to them. That whole "what matters to you" mentality. What I wasn't taught the opposite way as a doctor, but I was not taught to tune into it. And I think
Mhm.
that that's part of the preparation of youth is now how do you find out what matters to each
Mhm.
individual? Every patient is the only patient, and tune in on that. How do you
Mhm.
cope with the restrictions of a healthcare world that
Mhm.
A is costing too much now? What's your role? What's your part in getting those costs under control in a way that doesn't harm patients? How do you do that?
Mhm.
High levels of cooperation. Healthcare is
Mhm.
a team sport. I could see that with my hip replacement. I must have been cared for by 30 people through my time in the hospital, let alone afterwards. And if they weren't a team, then I couldn't be well served. The beds would change unpredictably. My pain wouldn't be responded to. People would forget my particular nutritional needs and so on. So this skill to be a team, it
Mhm.
isn't like it isn't a luxury or a kind of an add-on to professionalism. It ought to be at the core of professionalism. That's just some of the list, but I'm excited by all of that. In terms of using the AI and modern technologies, of course, the younger generation's ahead of us on that, but they need to be part of the inquiry as to how to make sure this is safe and good for patients.
Well, you mentioned AI, so we'll go there one more time in the conversation because we do have another audience question connected here, which is how do you evaluate the possibility of AI replacing doctors?
Well, I'm the wrong person to ask because I'm not technically equipped, but I've heard
Mhm.
lots of people speak about it. And the people I
Mhm.
most respect say, I think that framing is not quite where we're headed. I mean, there may be
Mhm.
particular specialty deeds where the AI will end up being better than the doctor. In fact, there's some interesting experiments in which compare, say, diagnostic decision making in certain realms in three modes by AI, by a doctor, or by a doctor plus AI. There are actually some papers in which the doctor plus AI performs less well than the AI alone. Doctors
Mhm.
cause deterioration in the diagnosis, but I think those are rare and probably special pieces. Most of the research, most of what the people I admire and respect in this field tell me is that the view of AI as an adjunct or the individual, the person, clinician as a partner with the AI is a much stronger model. And in the end, AI can't really hold my hand or tap my shoulder to reassure me the way a good doctor or nurse will do.
Mhm.
So I think it's an evolution. Care today is not the same as what it was, but I think the clinicians are still going to be essential. Um, there are some other jobs. I talked to a lawyer friend last week who said that the law firm that he knows has reduced its lawyer complement by a third because AI could do a lot of the clerical stuff that lawyers would do, and the same may happen to some of the healthcare industry. But I think there's going to be jobs for us. When people are suffering, they need a human face too. I still think that.
Mhm. Well, you said at the top of this answer that you were the wrong person to ask, but clearly you have a drawing from tremendous experience and expertise, some pretty clear thoughts on the limitations and the opportunities of AI moving forward. So thank you for sharing that with us. I'm going to zoom out just a little bit here over your long sort of public service to health and healthcare, not just in the US, but also globally. Over that time, we've seen tremendous innovation, robust research. Why isn't that translating to the system change that we're looking for in the US?
Because of incumbent interests, we have research. We know, for example, that it's far smarter to put funds into health generating features in communities. We actually know a lot about that. I've lauded the
Mhm.
work of Sir Michael Marmot. There's a book everyone listening should read called The Health Gap. If you want to
Mhm.
understand social determinants of health, read The Health Gap. It's all there for you. And it tells us what to do, but we don't do it. The
Mhm.
money remains in the hands of a highly technocratic system instead of shifting toward the community community needs, even in a wealthy nation like ours, and we're laggards there with respect to compared to other OECD nations. Uh, I think it's that we have in the United States a political circumstance in which wealth generates power, and power allows wealth to be concentrated, and that's a vicious cycle. All you get is
Mhm.
increasing wealth disparities and resistance to innovation, which threatened um, incumbent power, incumbent wealth holders. That's a political area. We're going to have a political struggle on behalf of people. So far, we have the vote as a tool, and hopefully, people will realize that when you vote for improving the conditions of society, the care of young children, the safety in the workforce and workplace, better education systems, better mass transit, food security, housing security. When you vote for that, you're voting for your own health. And when you vote against it, you're voting for deterioration of health and concentration of wealth. So this case has to be made politically, I fear. Whether local communities, states, towns, cities can take this up, and at a time when the federal policies are so wrong, so inimical, so ignorant with respect to the science, I don't know, but that right now, that's the place I'm placing my hopes. When this
Mhm.
dark age is over and we're back to a more normal governmental role, I think government still can be a leader in helping us be healthy, but we have to help it. We have to support it instead of attack it.
I will say a recent poll from the bipartisan/nonpartisan organization Disagree Better did show that healthcare costs and healthcare accessibility, those are issues that everybody agrees on, by
Everybody.
and large. So regardless of politics. So you did mention in your reply there, I believe it's Sir John Marmot, the creator of Marmot Communities, which leads me to my next question around like could you tell us a little bit more about that and as an example of what we can potentially learn or take away from other health systems?
Yeah, Sir Michael Marmot it is, and the
Sir
book
Michael
is
Marmot, thank you.
the health. That's right. The
Mhm,
Health Gap is kind of the book that puts it all together in 2015.
mhm,
Marmot lays out. Let's say you were a community, a mayor, a policy group, or a public that wants to be healthier. What would you invest in?
mhm.
And it lays out pretty systematically where the investment should be going. Well, now he's challenged communities to do that. He doesn't use the term, but I do. Marmot communities. There are now
Okay.
60 in the world, 60 cities and towns that have said, yep, we're going to move our money where our health is and try to seek it that way. Um, and it's pretty, we don't have time in this short interval. Maybe that's what I'll come back and talk about. Maybe we get Michael to join us.
Yes.
Uh,
Be great.
uh, so the roadmap is there. But
Uh-huh.
again, it's politics. Can we get the resources to flow there? Michael and I and several friends are thinking of putting out a challenge in the United States. Do you want to be a Marmot community? Because if
Mhm,
you, the city of Omaha or Nebraska or Jacksonville, Florida, or a small town in Michigan want to be a Marmot community,
mhm,
let's help them. Let's figure out, basically show them what the science says about where their resources should go. And you know what? They will get healthier. They'll live longer. They'll be more vital. Their kids will be more alert. We actually know how to do that. I have to say that the Make America Healthy Again stuff coming out of Washington is pretty much nonsense compared to what the science actually says. So we're another case where we're saying one thing and doing another. You don't cut food stamps and cut early childhood education and attack Medicaid if you really want to have a healthy community. So
mhm.
we need to hold people accountable for that.
Thank you. And we have just a couple minutes left, so I'm going to ask you two quick fire questions here right at the end. In just a few words, tell us what is most keeping you up at night about healthcare right now, and what is most giving you hope?
What's keeping me up at night is the midterms. Unless we change the
Okay.
direction of federal policy, we are really cooking
Mhm,
our own goose. So
mhm.
that's the answer. The midterms. Sorry.
Both,
Uh,
both, both keeping you up and giving you hope.
the most hope is every time I speak to a young person. When I speak to
Mhm,
people in the youngest generations now about to take over, they know, they understand, and
mhm,
I think they're going to be a little bit angry that we haven't handed them a world that was more fit for health and well-being. So power to the youth.
And
Uh,
final question, and this one's for the young people. Who would you recommend they follow in terms of healthcare leadership these days? Who can they learn from and be following?
follow their hearts first. I mean, what you
Okay.
don't, the world may be telling you that your instincts are wrong. That no, your instincts are right. So I just say, trust yourself. Get
Mm.
together. That is, you can do more
Uh-huh.
together than separately,
Mhm.
and then become, if you're in healthcare, become scholars of health. Read. Actually, my assignment: read the health gap, and then say, what
Mm.
does that mean for me, and what can I do about that? So stay together, stay confident, and get the science under your belt.
Dr. Berwick, thank you so much for your time. We certainly appreciate it. And as forecasted, we did not get to all the questions that came in for you, so we will certainly be inviting you back. Thank you again for your time today, and thank you to our audience for joining us today on Voices That Echo.